COVID-19 has impacted my department at NYU Langone Hospital. I hope that the experience in our department will be informative for yours. I was on the epilepsy consult service in April during the peak of the pandemic, so I'll talk to you mainly about my experience during that time. I'll be mainly focusing on epilepsy, but I'll try and incorporate how this has also impacted general neurology as well. Just want to mention briefly that I have no disclosures. Just want to start off with a timeline of what happened in New York City, as the timing of first cases and peaks are different in different states. So our first confirmed positive patient at NYU Langone Hospital was on March 11th, though likely COVID was around for weeks before this in New York City. March 12th, the governor issues a restriction on large gatherings, and then several days later, the governor issues cancellation of all elective surgeries. Our department shortly after cancels all elective adult EMU admissions, and then on March 22nd, the governor issues a stay-at-home order, and then we subsequently cancel all of our pediatric EMU admissions, as well as postpone all of our non-urgent outpatient EEG studies, with only our EEG testing office open 3 days per week. In addition, we stopped performing hyperventilation during our routine EEGs to minimize any potential risk of spread for COVID-19. Several days later, March 25th, we also reduced the hours of our epilepsy office to only 2 days per week, mainly to see in-person visits that can't be seen via telehealth or telephone, such as programming for VNS or RNS, but otherwise all visits are now being conducted through televideo or telephone. That's similar for the other neurology departments as well. Meanwhile, the number of COVID-19 cases is increasing at our hospital, and our inpatient neurology floor, as well as our neuro ICU, are converted to COVID-19 units, and our neurology patients are moved to other parts of the hospital. The peak at our hospital of COVID-19 cases was around the first week of April, and we eventually saw a decline in the COVID-19 admissions about mid-April. We did see a significant number of intubated COVID-19 patients having prolonged need for ventilation, and thus they converted our neurology floor to chronic ventilator unit. On April 29th, we discharged the 1,000th COVID-19 patient from our hospital. And, things were declining, things were improving in our hospital. We started seeing decreasing number of admissions and intubations. So eventually on May 4th, our neuro ICU was converted back to converted from a COVID-19 unit to a neuro ICU. And then just this past Monday, our epilepsy, as well as our neurology offices, are reopening fully to 5 days per week, with all staff obtaining PCR testing prior to the reopening, and then the staff having daily temperature and symptom checks upon arrival each day. And next week, we expect our neurology floor to be converted from a chronic ventilator unit back to a neurology floor. And in anticipation of this, we started scheduling some of our more urgent video EEG admissions that had to be postponed earlier. And so due to COVID-19, we had several changes to our inpatient EEG protocols, with the main goal to protect our EEG technologists from getting sick. Particularly for routine EEGs, the technologists have to place the full montage of electrodes for just a short period of monitoring. They have to stay in the room for the duration of the monitoring, so all those increase the risk of COVID-19 for them. And because the risks are high for the technologists, we had a safer alternative, which was the Ceribell, which could be placed much quicker, so we utilize this instead. In addition, all of the continuous EEGs now had to be discussed and approved by our epilepsy service prior to connection. And this was mainly to triage if the continuous EEG was necessary, again, to avoid risk to our technologists, but also because at times we were short-staffed because some of our technologists were redeployed to COVID-19 duties or were out sick. And so if we felt that the clinical picture was low risk for seizure, we proceeded with a Ceribell instead of having them placed on continuous EEG. In regards to what we saw were the common reasons why EEGs were requested in COVID-19 patients, we saw a bimodal distribution of when EEGs were requested, either early in the hospital course, usually within the first week, or late in the hospital course, 2 to 4 weeks in. And early in the hospital course, most common reasons were seizure exacerbation, post-cardiac arrest, or evaluation of paroxysmal episodes. And later in the hospital course, the majority of the reasons for the EEG was because of persistent encephalopathy after weaning sedating medications. And overall, we found that the incidence of seizures in COVID-19 patients is low. I looked at the numbers when I was on for 3 weeks in April, and we had connected 30 COVID-19 patients with continuous EEG. We performed 12 Ceribells, and I believe only one of those patients was a non-COVID patient. And we saw about 7 patients with seizures during this 3-week period. With a denominator which is probably close to 1,000 patients who were hospitalized during that time. And in those 7 patients who had COVID-19 and we did see seizures, one of them was post-cardiac arrest, who had myoclonic seizures. One was a witness seizure in the field and had cardiac arrest upon arrival. 2 were found to have subacute infarcts. 2 had a history of epilepsy. And one, the etiology was unclear, unfortunately, was unable to get an MRI before he passed away. Reassuringly, we didn't see any subclinical seizures or non-convulsive status in our hospital, though it is plausible that a COVID-19 patient could have subclinical seizures or non-convulsive status, particularly with all the associated sequelae that have been reported, such as hypercoagulability, stroke, multi-organ dysfunction, metabolic derangements, anoxic injury from cardiac arrest, and others. And these observations we saw at our own hospital are in line with recently published articles that I listed on the bottom right corner. Asadi Puya published a review article that the incidence of seizures in COVID-19 patients is low, and typically they're acute symptomatic seizures, similar to what I just mentioned. And then Mao and Liu published a retrospective case series of COVID-19 patients in Wuhan, and found in their group of patients that the incidence of seizure was very low, either 0% or 0.5%. One thing that we did observe was that about 2 to 3 weeks after the peak of COVID-19 cases in our hospital, we started seeing an increasing number of neurology consults and requests for continuous EEG to evaluate for persistent encephalopathy after weaning sedating medications. And due to this, we came up with some guidelines for our residents and fellows on how to work up encephalopathy in COVID-19 patients, with an emphasis on what studies are necessary and when to try and minimize, conserve resources. And so for head CTs, stroke codes, acute neurological changes, or if they're unable to get an MRI, we recommend an MRI when they're encephalopathic and unable to attend after being off sedation for over 5 days. And then for Ceribell and EEG, we basically recommended that when there were clinical findings concerning for seizure. So, we recommended to the residents fellows to bring the Ceribell with them to the bedside during their assessment. So if they had any concerns, they can place the Ceribell on right then. That would reduce the number of times they'd have to re-enter the room, conserve PPE, and things that they could look out for, including anything from nystagmoid eye movements, hippus, facial myoclonus, twitching or jerking of the limbs, unexplained autonomic variability, especially if they have severe neuropathy or myopathy. And then also, if they're encephalopathic and a history of epilepsy or dementia or a pre-existing structural brain abnormality, they are higher risk, and so they should consider Ceribell EEG at this time. And then also if they're encephalopathic after being off sedation, and depending on the duration of the sedation. So if they've been on sedation for less than 5 days, if they've been off of it for 2 days and still not waking up, then, consider getting Ceribell EEG. And then if they've been on sedation for longer than 5 days, and it's been 5 days since they've been off the sedation, and again, to consider Ceribell EEG to rule out subclinical seizures, and especially if they've had imaging and it shows some type of supratentorial pathology, like a small stroke that doesn't explain the degree of encephalopathy. And then lastly, for an LP, if there's a concern for infectious or inflammatory process, in addition to COVID-19 and imaging, or the Ceribell and EEG don't explain the degree of their encephalopathy. So just in conclusion, we had to make some changes to our inpatient EEG protocols due to COVID-19. We saw a bimodal distribution of when EEGs were requested, both early on in the hospital course as well as later in the hospital course. Overall, we saw that the incidence of seizures in COVID-19 patients is low, and we did see after, several weeks after the peak of the COVID cases in our hospital, a lot of consults for persistent encephalopathy after weaning sedating medications. And so we create some guidelines to try and minimize utilization of resources. Thank you, and yes, I'll take questions at the end.